Chapter 3 Techniques and Equipment for Physical Assessment. Starting off, we need to talk about infection control practices. Standard precautions apply in all healthcare settings. And your number one, this is going to be especially important when it comes to ATI NCLEX. The number one best method to prevent infection spread is going to be hand hygiene. Make sure we're washing in, washing out. Also, utilizing the correct personal protective equipment, whether this patient's on standard precautions or on up to contact, droplet, airborne precautions. We need to make sure we're aware of what type of precautions our patient's on and we're effectively using our PPE. We also need to be mindful of latex allergies. This is still an issue in modern healthcare, though not as much. Latex has been removed from a lot, especially with gloves. The gloves you're going to see outside the doors at most major hospitals are going to be the non-latex variety. Here we have a diagram, again, washing hands. I know it sounds basic, but this is actually something that comes up a bit in ATI NCLEX especially. And again, the first one's always going to be using warm water, warm soap and water. We don't ever want the extremely hot water. We obviously don't want cold water. The correct answer is going to be using warm water with soap, washing the hands for 15 seconds, and always keeping the hands below elbows as well, so nothing is running down the arm. Our first assessment method we're going to talk about is going to be inspection. The physical exam begins with inspecting, visually looking at your patient, looking for everything from any abnormalities to movement, posture, and the data obtained by smell are also part of inspection. The patient's draped appropriately to maintain modesty while allowing us sufficient exposure to be able to visually examine this patient. Use of equipment may also facilitate inspection. Things like a pen light for checking reactions to the pupils, an otoscope for the ears, an ophthalmoscope for the eyes. Next up would be palpation. Use the hands to feel the texture, size, shape, consistency of certain parts of the body. Again, we're looking for any abnormalities, any lumps, growths. Is it abnormally hard? Is it abnormally soft? Is it abnormally warm? Touch. Make sure we're stating the purpose. We're keeping the patient aware of why we're palpating, what area we're palpating. And again, wearing gloves, always keeping a careful eye on that standard precautions. For palpation, we're looking at the dorsal surface is better for assessing temperature. And by dorsal, we mean the top of the hand, the back of the hand. Good way to remember that is think of a dorsal fin on a dolphin. For palpation, light palpation is accomplished by pressing to a depth of approximately 1 centimeter. And this is used to assess again for pulsations, tenderness. A deep palpation may also be accomplished by pressing to a depth of 4 centimeters with one or two hands. And this is going to be used for things like determining organ size in the case of the spleen. The bimanual technique of palpation again uses both hands, one interior and one posterior, to entrap that organ or mass between the fingertips. We're trying to assess the size and shape of that organ without sending them to imagery. Next in our sequence would be percussion. This is again going to be an older method used to evaluate the size, borders, and consistency of internal organs without sending the patient to imagery. It can also be used to detect things like tenderness and the extent of fluid within the body cavity, such as being able to check waveforms for ascites or fluid accumulation in the abdomen. In direct percussion, you'd strike your finger or hand directly against the patient's body. Evaluate the adult sinus by gently tapping a finger on those sinuses. It can also be used to elicit tenderness over the kidney by striking that costovertebral angle. When you hear costovertebral angle, that's that angle of the ribs as they meet the spinal column. Indirect percussion, on the other hand, would require both hands. And in this case, you'd put the distal aspect of the middle finger on the non dominant hand over the skin of the organ. And then you would tap your own finger to, again, elicit that percussion within the patient. But you're putting the direct strike directly on your finger. Try to lessen that blow while still getting our percussion across. Here we just have another diagram showing how indirect percussion is accomplished. You see how they're placing that middle finger on the patient and then striking on that finger. When using percussion, there's going to be 5 tones that we need to be on the lookout for. The first is timpani. This is a loud, high pitched sound heard over the abdomen, not to be confused with resonance, which is heard over normal lung tissue. Hyperresonance, on the other hand, is heard over overinflated lungs, as in emphysema, versus dullness heard over the liver, and flatness heard over bones and muscle. And finally, auscultation. Auscultation is listening to sounds within the body, using that stethoscope. It's used to block out extraneous sounds when evaluating conditions of the heart, blood vessels, lung, and intestines. And that is a key factor I've seen come up in a bit on ATI and a few other NCLEX areas, is that stethoscopes do not amplify sound. They only block out the outside noise to allow you to focus on that one noise. Here we just have an example of auscultation over the back lung fields. And remember, when auscultating, we always want to go from a side to side fashion. That way we're able to compare both lungs as we work our way down. Patient positioning is going to be another key factor while assessing our patient. And it's going to depend on the type of examination. Whereas some we may want to have the patient sitting up, others may be, such as the abdomen assessment, may be better lying back in a supine position. Next up would be thermometers and taking a temperature. And there's going to be multiple different routes or tools that we could use. The first and increasingly more common is obviously going to be the electronic. Calculates and displays the temperature on a digital screen within 15 to 30 seconds. There's also the electronic tympanic. Temperatures are obtained by placing a probe into the ear, much like an otoscope, and are able to get a relatively accurate temperature. Another option you'll see out there is the temporal artery, where they're actually placing an infrared sensor and running it just right along the side of the patient's head to, again, get a temperature. And a stethoscope. These are those binaurals, as they're called, the classic stethoscope I'm sure you're all aware of and came in your lab kits. The tubing's usually polyvinyl, no longer than 12 to 18 inches. And again, these do not magnify the sound. They only block out all outside noise. Just another diagram showing you the stethoscopes. And just my own personal piece of advice, you don't have to run out and buy the most expensive stethoscope. Don't get the absolute cheapest one, but you don't need a massively expensive stethoscope as well. Like I've been able to get quality Littmans online for $30. The stethoscope's going to have 2 components. There's going to be the diaphragm, or the large flat end of the stethoscope, and that's going to be used for high-pitched sounds, such as breath sounds, bowel sounds, normal heart sounds. On the other hand, the smaller concave portion on the opposite side is called the bell. And this is going to be used to hear low-pitched sounds, such as bruits within vesicles, or adventitious heart sounds and valves. This is a fetoscope. It's a specialized tool used in OB to manually listen to the fetus. And everyone's favorite, blood pressures. Hopefully you guys are working and are good and polished up on your manual blood pressures in lab. Again, the Dynamap, it's fast, it's easy, it's quick, and in most cases it is sufficient. At the same time, manual blood pressures are essential. And anytime there's a difference between what the machine's showing and what you're reading as manual, your manual is the correct reading. Here's just some examples of different blood pressure cuffs, and they can vary wildly in size. Everything from that little teeny tiny one that go around your pinky they'd use in NICUs for preemie patients, versus ones that many of you may be able to even wear as a dress for extremely large patients. And it's going to be critical that we use the correct size cuff for each patient. Using a cuff that's too small will read abnormally high, whereas using a cuff that's way too big is going to read abnormally low. This is a pulse ox that again uses infrared light. We're putting it through the nail bed, capillary beds, and it's actually getting a reading of the oxygen saturation of that blood. Some key things to be aware of is, first off, females are going to have to remove nail polish for us to get an accurate reading with it. And we also want to make sure their fingers are warm as well. And scales, how to accurately get a body weight. This is very important, especially when we're talking about things like monitoring fluid status of a patient. It's very important we're getting those accurate daily weights on our patient. They also, many, as you've probably seen when you go to the doctor, they also can measure height as well, have that little arm attachment on them. And they're sensitive to 1/4 of a pound. And visual acuity and screening. This is most effectively done with what's called a Snellen chart. I'm sure you've done it at the doctor's office, and also, especially here in Ohio, we have to complete to renew our driver's licenses. And it's going to be reading those lines off there, covering one eye, standing 20 feet back, and covering one eye and being able to read a line that they point to. And with that, we're going to be able to get an accurate reading of how effective do they are they able to see. What do these numbers mean? You may hear the number. Normal vision is going to be 20/20 vision. In the case of 20/40 vision, you are seeing at 20 feet what a normal person sees at 40 feet. So, what a normal person would be able to read and pick out with their vision at 40 feet, you are having that diminished of a level because you're only seeing that at 20 feet. On the opposite end of that, if a patient was, say, 20/15, they have better than normal vision. They're seeing at 20 feet what a normal person would be able to pick out at 15 feet. An ophthalmoscope. This is going to be that tool that they can shine a bit of a light in the eye, and they're actually able to focus in and see the back of the retina, identify conditions such as macular degeneration. On the other end, they could actually use an otoscope as well, and that would be a tool that they can see into the ear and back visualize that tympanic membrane. One key thing to keep in mind for children 3 and younger, you would pull the earlobe lightly down and back to align that earlobe. Versus adults, you would pull it lightly up and back to align that earlobe. This is a pen light. Again, we should always carry one, and it's a quick way to assess that pupillary response, that pupillary constriction in response to that soft light. There's an acronym we're going to talk about when we get to our eyes section. It's called PERLA. Are those pupils equal, round, reactive to light, and accommodating? By accommodating, they mean are they able to focus on an object? And a ruler and tape measure, which, just as you would probably guess, are used to measure the circumference or width. This is especially important in things like, again, ascites, patients that are accumulating large amounts of fluid in their abdomen. We'd want to measure their abdominal girth every day to see are we gaining more fluid? This would be a nasal speculum. And just what it looks like, it would be a tool to slightly open up those nares to get a better visual of the septum and inside of the nose. A tuning fork. And this will be especially important when we're testing hearing. Because a tuning fork, we're going to be able to both test the sound conduction, but we're also going to be able to test the patient's bone conduction. Because your ears actually process sounds both from the air as well as vibrations from the bone. A percussion or reflex hammer. I'm sure you're very well aware of this as well, and that it can be used to test that patellar reflex within the knee. A Doppler. This is going to be another one that hopefully you're able to see at clinical here early when you get out there. And that this is going to be important, especially when we're unable to palpate, say, pedal pulses. We still have to be able to confirm that that patient has perfusion to their foot. But maybe due to cellulitis, maybe due to edema, swelling, whatever reason, we are unable to palpate that pulse within the foot. We'd use the Doppler to go in there and make sure that we can hear a pulse and we are able to confirm they have perfusion. A goniometer. This is going to be especially important in ortho, is that we can accurately measure the extension of joints. And calipers. These are important for measuring skin fold thickness. A vaginal speculum, just like with our nasal speculum. Open up there and get a better view inside. An audioscope. This would be used to assess the ears, but in this case, we can actually assess the patient for hearing very specific tones. An audiometer. Any of our veterans out there, I'm sure you've done this a lot coming in and out of the military. I used to hate this one. I'm always hearing phantom tones and I'm clicking the button when maybe I'm sure, maybe I'm not. And again, maybe I'm missing a couple tones in my hearing. A monofilament. This looks like heavy fishing line. And in this case, you'd use it to assess whether the patient has feeling in all areas of their foot. This can be especially important in cases of things like diabetic neuropathy. A woods lamp, much like think of like a black light, but in this case it's a specific frequency of light, and we're able to illuminate and see things like fungal infections on the skin much more apparent than maybe we're seeing in normal fluorescent lighting. A magnification device. Again, this one's probably pretty self-explanatory as well. Think of much just like a magnifying glass. We're able to magnify and get a better picture of small abnormalities. And wrapping up, the nurse is preparing the room for the dermatologist. The nurse knows that the patient may have a fungal infection on the left leg. Which tool is not part of the setup for this assessment? That be a woods lamp, a magnifier, a monofilament, or a ruler. Well, obviously, we're going to need a woods lamp to illuminate that fungal infection. Same thing with a magnifier. That monofilament, on the other hand, would be only used for cases of diabetic neuropathy to test sensation. And the ruler is going to be necessary as well because we want to measure how much area of that skin is infected. And for our last slide, collection of objective data from a patient with a swollen left elbow includes what piece of equipment? A magnifier, a blood pressure cuff, a Snellen chart, or a goniometer. And obviously, as we just covered, that's going to be a goniometer to measure the amount of extension and contraction we're getting out of that joint. But anyway, that's all I got for this chapter. I'll see you in chapter 4.